Might be some more folks that come in, but thank you so much. It's great to see all of you. Oh, we have some more people coming in, so should I wait a couple minutes? You guys can move to the front if you want. It's kind of a small group.
Also get some.
Okay. Yeah, I know that Section 1115 waiver session is real popular, but we're really glad to have all of you here. So, my name is Barbara Otto, and I have the great pleasure of being a partner in the Supportive Reentry Network Collaborative and working with all of these amazing women who are also on the panel with you today. We're going to do things a little differently. We're not going to have separate presentations. We have one presentation, and then I'll be moderating, and we want to make sure we leave enough time so we can answer your questions at the end of the panel. But I'm going to just get started and introduce our panel while we're waiting for some more folks to come in. On our panel today, we have Sodiqa Williams. Sodiqa Williams is the Senior Vice President for SAFER's Reentry Services at the SAFER Foundation. Sodiqa oversees community programs providing wraparound reentry support, behavioral health services, training, housing assistance, and linkages to primary care providers. With extensive expertise in government relations, public advocacy, and groundbreaking initiatives like the Supportive Reentry Network Collaborative and the SAFER Act, Sodiqa has been working on these issues like occupational licensing law in Illinois and other impactful initiatives impacting people involved in the criminal legal system. Sherie Arriazola Martinez is a leader with over 15 years of operational and policy experience concerning behavioral health and reentry. She's also the owner of MIMS Consulting. Before starting her own business, Sherie served as the executive director of social policy and systems at the Cook County Jail. And prior to that, she served as AVP of behavioral health at the SAFER Foundation. Governor Pritzker in Illinois appointed her to his opioid prevention and recovery steering committee. And she's also been tapped by CMS for the Medicaid Reentry Working Group under the Support Act. And finally, we have with us Angie Mecagni. Angie is the Reentry Administrator of the Illinois Department of Corrections. IDOC's Reentry Unit was first established in January of 2020. She has spent most of her career working in state correctional facilities and serving justice-impacted citizens. In her current capacity, Angie oversees transitional housing and placement, field services, and all IDOC reentry programming initiatives. And she also works on partnerships pre- and post-release to include benefits enrollment and our state ID program. So thank you all for joining us. As I said, for those of you who entered a little later, we're going to do this a little differently than other panels. We're going to present just as one group with one set of slides. I'll be asking questions and each of our panelists will be commenting on them. But as we get started, we thought what we might do is talk to you about our story, starting with sort of the high level takeaways we hope that you are able to take from this session. I think our number one thing I will say is that reentry must be person-centered and it must address the health and literacy needs of people returning to community. We've talked a lot over the years about the problems and challenges faced by returning residents. But the thing I think we never really dig in on that I feel like our collaborative, the Supportive Reentry Network Collaborative, deals with is that a lot of the programs for low-income individuals often have eligibility criteria that excludes returning residents. And a classic example of this is like housing. At least in our state, our public housing authorities and our HUD continuum of care all have very restrictive eligibility criteria that require that an individual, for example, be street homeless for 90 days prior to being eligible for any type of housing assistance. And this disproportionately impacts especially Black and brown men that are returning from a carceral setting. Another thing we hope you take away from this is that community level providers are critical to the success of reentry. So there must be an investment in the type of infrastructure needed, in addition to investment in allowing them to ramp up their services. Community level providers are not molded in the medical model that most of our Medicaid billing agencies are. Community level providers are not used to being paid after they deliver the service. They also don't have the infrastructure like the back office operations to be able to do this work. And so we really realize as the SRNC how important it is to build up community providers. Community providers also need flexible and accelerated or advanced funding. I know Sodiqa is going to speak to this, and Sherie will as well. But it would have been very difficult for us as a Supportive Reentry Network collaborative to really effectively engage without receiving some accelerated funding. Safer Foundation, who leads and is the authorized representative for our Supportive Reentry Network collaborative, was not traditionally a Medicaid billing organization. They were a community-based organization that really needed to build its infrastructure, and both Sherie and Sodiqa will talk more about that. And then finally, we're so honored to have our partners from IDOC here because they've really embraced the work we're doing, and they really helped us do a lot of this cross-agency coordination and collaboration, and have really been leading efforts in our state to make sure that there's cross-agency collaboration that includes community-level partners. So I'm going to stop talking, but I guess I should introduce myself in that I am a partner in the Supportive Reentry Network Collaborative. I work as a part of the collaborative on sustainability and on implementation. But Sherie, I'm gonna start with you. Let's start with the need, and can you share with everyone here why there was a need for this specialized approach to reentry in Illinois?
Sure. Thanks, Barb. So when I say we, I mean people in this field, people doing this work have been advocating since the Affordable Care Act passed, and since our state decided to expand their Medicaid, starting with county care at the time, and then going into managed care. We've been trying to advocate for specialized attention to folks coming out of jail and prison, simply because people coming out, as you guys know, have higher rates of overdose. They're returning to communities that are, at least in Chicago, I'm sure that's true in other parts of the country, they're returning to the same communities that have the highest rates of violence, the highest rates of overdose, the highest rates of homelessness. And if you pay attention to people coming out, you have a real opportunity to not only address recidivism in regards to people coming back into the system, not coming back into the system. You have a opportunity to address things that have traditionally been looked at in a siloed manner. You can address things going on in the overdose epidemic. You can address homelessness. You can address violence prevention, because people don't come in pieces. Mm-hmm. A lot of people that live in these communities are impacted by several different things, usually related to poverty and racial inequities. But yet systems often approach these issues in silos. And so we were doing this work. And when COVID happened, it was a crisis, but it was also an opportunity to actually do the things that we had dreamed of doing, because we finally got permission to start using funds in a way that had not traditionally been allowed. So going back to March 15th of 2020, I'm going into the next slide. I'm sorry.
That's okay.
Safer Foundation, which is a nonprofit, community focused on individual men and women who have criminal records on their backgrounds. We were called and asked on a weekends if we would help men and women coming out who were being released early in the middle of the pandemic. So this was, I think, a day after everyone was running to the grocery store and, all the shelves, there was like no meat left on the shelves. And we asked how soon this was going to happen. And it was a Saturday at the time. And they said Tuesday.
I remember the phone call.
So we had 3 days to figure out, how we were going to help a large number of people. Safer Foundation had been helping people for years, but never in the middle of a pandemic and never a large quantity. So we quickly assembled a call center, a phone number that everyone can call. We worked with IDOC, our Illinois Department of Corrections, so that individuals can pretty much sign up if they want support from Safer. And then those people who signed, we would receive their consent forms, and then we would do the outreach to them. And we would call, sometimes the person wasn't out yet, and we'd be talking to a loved one. And then we reached that, it was usually like a grandparent or a mom or a significant other, and they would reach back out. So what we did was really just look at the most immediate needs. Where are you staying? Can you stay there for a while? Do you have, a lot of people just come out with the clothes that they had. So we tried to address like the most basic needs. And then once those things were addressed, then we would work towards employment, education, healthcare, substance use, mental health, whatever justice system mandates they had, whether it was going to get a mental health assessment, anger management, sex offender counseling, all of those types of mandates that I'm sure Angie could talk about more. But another critical thing was giving them access to a cell phone, because at the time everything had shut down. So a cell phone was critical, or phone was critical to gain access to any services at that time. And COVID, I believe, really opened the floodgates for, I think, funders to allow for more funding towards digital access, because we're in a new era. So we worked with AT&T to get access to some cell phones. We used philanthropy dollars to assemble like care packages, like a backpack, so people can, wherever they were going, at least they had something they could carry stuff in. When the city at one point decided to shut down the bus routes, and I was so upset. I was like, how do you expect people to get to work, if you shut down the bus routes? So we had set up partnerships with Lyft. There was just so much that happened. We put out a call to providers across the state. Our lieutenant governor at the time helped us do that, as well as our two trade associations, our Illinois Social Behavioral Health and the Community Behavioral Health Association of Illinois. Yes, we have two. And there was about, I think, 5 to 7 providers that responded out of all the providers that I'm sure received the message, and they said, we'll help you. And the significance of that is that there was no funding attached at the time. Right. It was crisis response. We had to go to our current funders and ask them to, if we could make some changes so that we can, meet people where they were at the time. I know I'm going on and on. So, basically the COVID just allowed us to do a lot of things that weren't allowed before. And then, sooner or later we were like, this is a great model. How can we sustain it? And that's when we were presented with an opportunity from our state Medicaid agency called Healthcare Transformation Collaboratives. And eventually we transitioned into that. And so I'll stop there And I don't know how many, I apologize if I took some of your.
No, this is great. So as with every crisis, necessity is always the mother of innovation. And lucky for us, Sherie was able to compel a lot of providers to come to the table. So when our state did the healthcare transformation collaboratives, which Sherie is going to talk a little bit more about later, how the legislature put that together. But through directed payments, we were actually able to set up and formally pay some of our partners through the Healthcare Transformation Collaborative. But before we get there, Angie, what innovations do you think IDOC was able to do simply because of COVID? Because all of these factors kind of lined up to make the Supportive Reentry Network Collaborative possible.
Absolutely. So COVID, clearly it was a crisis, right? But in our facilities, we were very concerned about congregate living and the fact that contagious diseases spread so quickly, right, in custody because everybody's really in the same place. And so it caused us to really look at the statute that was in place that perhaps we weren't using very well before, or we had kind of stopped using. So contrary to popular belief, the Department of Corrections, or at least in the state of Illinois, cannot do anything that is not in statute. That's what guides all of the operations. And so if it hasn't been written into legislation or some sort of directive, that's what allows us to do what we do, right? And so we looked at the electronic detention, medical furlough policies, and then the earned discretionary sentence credit, which really allowed us to review people. People still had to fit in, meet eligibility criteria. We didn't just open the doors and release everyone, but it did allow us to decrease our population and really get people into appropriate environments. So on electronic detention, people were able to serve some of their sentence at home on ankle monitors, so monitored by parole and with all the stipulations in place. We also utilized medical furloughs for people that maybe would be better served in a nursing home, or maybe could be served at home with home health or whatever services needed to be provided. And then the earned discretionary sentence credit was simply a review for people to be able to get additional sentence credit that would have moved them closer to their release date and ultimately out. So it felt like everyone was releasing
Clarify, alluding to that.
all at once. All at once. It's totally fine. But people were getting out at what felt like a high rate of speed, and we wanted to make sure that we weren't just releasing people without services or connection to care. This was a difficult thing for anyone to navigate, but especially if someone had served 20 years in custody, right? There's challenges to reentry as it is, but then adding the pandemic on top of it was an extra layer of difficulty. So those are great opportunities, and we are grateful to SAFER for taking that call and really meeting us where we needed to be at the moment. They do a great job and are a great partner to us. COVID also helped us to use dollars to enhance our technology services. So in the state of Illinois, we had been a little bit behind on technology. We were able to use some money to get WebEx TVs in each of our facilities. And so what that allowed us to do was to have inreach from the community. In the Illinois Department of Corrections, we do reentry summits twice a year for people who are getting ready to release from custody. And we bring community agencies and providers and vendors and all of the organizations that serve our population into the facilities so that people can meet with them, meet face-to-face, get more information, contact or be in communication with the organizations that will serve them upon release, right, to help them navigate reentry and meet their needs. Well, obviously, we weren't able to do that during COVID. And so we instead launched an InReach WebEx series in April of 2020 during Second Chance Month. We got all of the same community providers and even more because they didn't have to travel statewide. And we were able to have multiple facilities on at one time. It was live interaction. People could ask questions from in custody, get their answers in real time. And we, in fact, continued that series because it's been so productive. We have continued that to this day, but that really helped us to move forward. We also really enhanced coordination with other state agencies. I don't know if you know this, but siloed work doesn't work.
Right.
And so it really helped us to partner with the Secretary of State. We launched our state ID program during COVID. We thought we were just going to be able to have the Secretary of State come do mobile units to help people get state IDs. the DMVs were closed and there was a risk of spreading COVID. And so we stopped that and instead grew another process that we also still use today, where individuals we process the paperwork, we work with the Secretary of State. There's no physical interaction. It's all done via secure transfer. And we're able to get people their 5-year state IDs prior to release. We also launched the enrollment of individuals in Medicaid, Illinois Medicaid, within 60 days of their release. And then after that, because we had a good model, came SNAP benefits. And so we worked with HFS. We do both of those enrollments, and those have continued and have been very successful. In addition, it's helped to enhance coordination of referrals with community partners, which leads us to the Safer Reentry Network Collaborative. That's been successful, and I'm excited to continue to discuss that.
Great. So, Angie, do you think you could talk a little bit about the collaboration that what you've learned from collaborating with other state partners and with the community organizations when it comes to surfacing some of the challenges around reentry?
Absolutely. In collaboration, we've learned a lot of things. The collaboration has been productive, but as with any work, you learn what the issues are, right? And where the gaps are. And so an issue that continues sorry, I misplaced my notes here. I'm not sure if I've had enough coffee or too much today yet. So cross-state agency coordination, again, siloed work doesn't work. So that was made clear to us. And we also know that there is cross-agency coordination is necessary really to correct or fix issues, close those gaps that impact returning residents. We learned that the release of suspension of important benefits like Medicaid and Social Security upon release, like immediately upon release, are necessary. And so we worked hard to coordinate with HFS on that issue. The way that our program stands now is that an individual's Medicaid benefits are active within 48 to 72 hours of release, but retroact to the date of release. And we're able to help with that process when needed. We have also worked out a system to where we're able to work with the local HFS offices to where if an individual is going into a nursing home or another placement that requires those benefits immediately on day one, we're able to work with them. They'll unrestrict them before release to be utilized immediately. So that's great. We have worked to build up coordination with the Social Security Administration on SSI and SSDI benefits. There are other social determinants of health, right, that we keep talking about that are important both in everyday living, but also with the reentry population. And one of those is housing.
Mm-hmm.
There's never enough housing. We've been working with the Illinois Reentry Council and BARB, SAFER's involved in that, on a housing assessment survey that will help us to identify people's needs long before they release so that they can eventually get to care with the appropriate services attached, or those referrals could be made far earlier so that connection can be made and warm handoffs can happen pre-release. And then we've allowed for coordination with DHS on some housing as recovery and high need placements. Sherie alluded to the layers of people, right? And what we know about returning residents is that criminal backgrounds are hard. And when we layer additional issues on top of that, health problems, behavioral health issues, mental health needs, all of the pieces, housing, they become complex cases that there don't seem to be enough resources for. And so the Housing as Recovery program has been able to assist us with some high need behavioral health placements. And we know that there has to be cross collaboration on parole mandates or the prisoner review board orders that people leave custody with. So Sherie, you mentioned that. That would include behavioral health evaluations is just one of those mandates that requires further coordination with HFS on the provider guidance and how exactly those maybe should be handled to best benefit everyone involved.
That's great. And so I feel like Sherie and Angie kind of laid out some of the environmental issues that the Supportive Reentry Network Collaborative is trying to address. Sodiqa, do you want to talk a little bit more about the model and the work that SAFER's doing?
Sure, thank you. We have become a nation that criminalizes trauma. Trauma looks like events with community violence, personal violence, poverty, racism, oppression, illness, neglect, homelessness, and imprisonment. Many individuals in Illinois have experienced at least one of these incidents or events of trauma, if not all of them. So when we talk about what life looks like upon release, whether from Illinois Department of Corrections or Cook County Jail, we have individuals already experiencing trauma who are getting released. And historically, before the Supportive Reentry Network Collaborative, we've had a lot of programs and a lot of different agencies that have existed and that have been invested in, but there have been no seamless, infrastructure to really be there to address the needs. And getting back to the notion that we criminalize trauma, I remember, I will never forget, there was a focus group of our clients because we were trying to assess what kind of services we needed to provide to really help them. And we had several people say that they wanted to kill themselves or that they'd rather go back to IDOC because it was too hard to get the services that they needed. Mm-hmm. That they would call all these different agencies and they would get the runaround, they would get a voicemail. And it was just such a process to just try to get the basic level of support. And they had to go to all these different places to get the assistance that they needed. And that in itself was traumatic because, they're feeling the weight and it's kind of like, the clock is ticking upon release. It is well known that, the likelihood of a person to end their life, or to, overdose or any, if they have a serious medical condition, it's within the first 2 weeks. Mm-hmm. And so not only is it a pressure on them, depending on wherever they're released, but it's also for their family, if they're or the people in their lives, if they're asking for them for assistance. So it really is truly about life and death. And so before, without a reentry navigator, there is no right or standard way for individuals to reenter their communities. Now we have the Office of Returning Residents at the city level, and Safer was a part of that, I have to say. But anyway, but, I think now we're working with IRC and others regarding having, a more standard approach to reentry. But I want to say this. When we talk about reentry, I believe that the work we're doing with Supportive Reentry Network Collaborative is taking it to the next level because historically, it's been about public safety, but now it's public safety and public health. And it is through the lens of public health because we need to stop treating people and criminalizing them and locking them up for the trauma that's happened in their lives. And we need to start offering them benefits like we do in any healthcare setting to support them in the way that they really need it. And so, that is kind of a state. So when you look at the slide, and I can't really,
this is the maze.
Yeah, the maze, and it's pretty much what I said, you got to get housing, you have to have employment, you have to have, medication, you might have behavioral health, mandates. Yeah, you might need an ID, which was a major issue, during COVID, but you're in a maze and it's to what I was just explaining. So with the Reentry Navigator, and this is where the Supportive Reentry Network Collaborative comes into action. It really is symbolizing hope for returning residents because we're coming and saying, we are your concierge service. We're here. Here are all the benefits. You tell us what your needs are. And we're going to structure, a service plan with short-term goals where we're going to stabilize your immediate needs. And we're going to help map out your transformation. But, we're not the ones that are holding the power. We want to empower you. We just want to be your navigator. We want to be your guide. We want to open doors. We want to facilitate and provide warm handoffs within the collaborative infrastructure to ensure that you're going to get the care that you need. And so that's a Supportive Reentry Network Collaborative. And so it's really, we really need to start calling them cross systems navigators because they're at the intersection of healthcare, behavioral health, and health related social needs and the criminal legal system, which is very important because we talk about technical assistance. You talked about some of them, but there are a lot too, right? I think what makes the collaborative really interesting are the partners that are part of it, because we have community-based organizations, some of them larger and then some small that need the technical assistance. We're working with the FQHC and hospitals, and behavioral health providers. So we're bringing a holistic perspective to the table, and everyone has a different lens, and we're all educating each other. And I think what is particularly important is that the communities that are part of the collaborative are really where a lot of, or the majority of people are returning to Cook County from the Illinois Department of Corrections. And so we have 8 partners, and I'm going to say their names because I really believe in that you have to, give acknowledgement and recognition, because many of those partners did this work for free. We sent out the bat signal. And it really, people just came forward and organizations really, and Sherie was the woman, man, still today, and they came forward and they didn't have the funds, and we made it happen because we knew what was going to happen to people if we didn't step forward in that moment. So Healthcare Alternative Systems, or HAS, Partner Alliance Health, CAM Alliance, Transforming Reentry Services, Get to Work, Cook County Health, Legal Counsel for Health Justice, and Smart Policy Work. And so it's a comprehensive community-based approach that focuses on a specialized human-centered approach to addressing the needs of individuals that are returning from the Cook County as well as Illinois Department of Corrections. And it's holistic, because we really are, and I didn't mention, I mentioned housing services, but we really are trying to look at all the needs that they have and make sure that we can provide it to them as seamless as possible. And it's with the trauma-informed care. And so that's where our reentry navigators come in. We really prioritize having navigators with lived experience that will be able to really relate and connect to the individuals that they're serving, because we have found, again, that you learn when a person is explaining their needs and identifying what they need. A lot of time people are going to say, we need our mandates right now, we need our quarters. And so they're not thinking about health. They're not thinking about, do I need to go to the dentist? It's either mandates or housing or a job, so they're not going to open up about if they have, a mental health need, or if there's a substance issue or dependency that they need addressed. They won't do that unless you build a relationship with them. And so it's really critical that our navigators are trauma informed and trauma responsive to really understand, especially if a person is sharing with them any trauma that they've experienced, and making sure that they incorporate that in their approach to servicing them. We offer a range of services that promote health and wellness. So substance use treatment, Sherie said a lot of it, navigating public benefits. We do notice the difference. Government ID assistance, health and behavioral services, employment services, housing assistance. And housing assistance, I have to pause here, and I'll talk about the numbers. That is a big deal. So HFS funded us. They allowed us to buy property. So we were allowed to buy properties where we could house the participants, and we were able to fund a housing team. Our housing team has been going around Cook County and pretty much recruiting landlords. We have significant issues when it comes to individuals with records getting housed, but because we built, we pretty much got blocks of rooms that we agreed at certain rates, and because Safer Foundation was able to sign the lease for whatever subsidy, because we braided our funds. This has all been braiding funding. We received a good amount of money from the state, but we had to braid funds. So HFS gave money for the housing, and then we stopped funding to provide subsidies, whether it's 6 months up to a year, to help get them stabilized, get them housed, help them get a job, and any other services that they receive. But housing has been critically important. We help navigate court mandates and parole requirements, SSI, SSDI, as well as transportation to work. So that's the services that we provide. The navigator really is at the core of it. They make referrals to the partners after they do the assessment and the service plan. And to make sure I'm not missing anything. But also, I think it's also important to mention that we have had a major focus in year 2 on health plan benefits. So we are working with the MCOs. Our navigators, like I said, when we started, it was like reentry, their reentry. I literally had, and Barb was like, I had to stand on the table and be like, we are we are healthcare ambassadors. Like, this is our moment because, of course, I'm passionate about it because I have uncles, I have people in my family. Like, this is our opportunity to actually improve health outcomes. Like, even though we have people who are at the worst point of their lives coming to us and we need to help stabilize them and help them on their journey, health is a major part of that. You can't go to work if you're not healthy, And so we have done trainings with our navigators on healthcare, health plan benefits. We make sure that they have insurance. If they don't have insurance, we make sure it's any Medicaid redetermination that we get them signed up. We check to see if they are already enrolled in the MCO, and if they're not, we inform them of their rights and educate them on that. We have primary care providers within our network that we make sure that we're linking with. They don't have to come in our network, but we do share, that with them. And so I think that's really important as well. And I think with another important part is the infrastructure work that has went into the SRNC is not to be understated. It took at least a year and a half to get over the legal stuff.
Right.
The reciprocal releases so that we could share all the information within the collaborative to really talk with our partners and have integrative staffings where we're talking about the clients, where we're talking about, what their needs are and how they're progressing. As well as like when we started this thing, we didn't know, we wrote it in, but like when we started working, we were like, oh my gosh, we need IT support. We need a system.
We need electronic health record.
Yeah, we need what else? Quality assurance. We need compliance.
HIPAA training,
billing.
health literacy,
and I mean it. A lot went into building up the infrastructure and the governance structure. Working with our partners, we meet with them monthly where we talk about the trends and data and different things, whatever we want to prioritize, whatever outcomes we want to improve. We also have a leadership, that we're meeting with as well. And so that I just want to make that point because with any community-based approach, and I believe that it should be community-based, or any approach when it comes to really looking at how we can improve outcomes for this population, and I would say other vulnerable populations, this infrastructure part, it's not enough to just make referrals to community-based organizations. We have to understand a lot of community-based organizations don't have that kind of infrastructure to support it. I'm sorry, I went on a tangent. So
I know we're starting to run out of time, so I want to get you into the data section. But one thing that Sodiqa, I think is important for us to share with the group is that a lot of what we did is we tried to build a benefits network for men and women returning from corrections. Like it's their benefits network. We actually created a benefits card for them that has their reentry navigator's name on it, their MCO, their Medicaid RIN. That way we're teaching them how to use healthcare throughout the process. But Sodiqa, why don't you talk a little bit about our metrics? I think this one is really important. When we look at how many people we've served, of course, this makes sense, more men than women. It follows some of the national data, but this is a really important slide.
Yeah, I mean, it's showing, I think, what a lot of if you work with, oh no, we're almost out of time.
Okay.
Okay, so focusing on referral, we found that the majority of them are behavioral health services, with housing coming up next, which is no surprise because people need housing in order to be stabilized. And of course, we had appointment, and you can see here, but I just real quick. No, I'm not going to go through the numbers.
We also have a full complement of slides, which you will have access to. We pared them down just for this presentation.
There's photos.
Yeah.
Yes,
so we did see that domestic violence mandates increased throughout the period of time that we've been doing this work. And also transportation, we found we definitely probably will have to scale up because we have a need to provide more transportation to get people to work.
Do you guys want to talk just a little bit about the healthcare transformation collaboratives before we launch into questions?
Yeah, so I think it's just an important point to note that the healthcare transformation collaboratives that we're talking about was an initiative created in Illinois specifically by the state legislature in collaboration with our state Medicaid agency. In Illinois, it's called the Illinois Department of Healthcare Family Services, or HFS. And there was a lot of advocacy on behalf of the Black and Latino caucuses in our state legislature, to ensure that funding was going towards providers and communities that were still not only were they trying to get acclimated to operating in Medicaid, but they were also impacted by a 2-year state budget impasse because of political stuff going on in our state at the time. There was 2 years without a state budget for human service agencies, and a lot of providers had to take out lines of credit to survive. So Illinois expanded Medicaid, they expanded managed care, and then the budget impasse, and then COVID. Mm-hmm. So basically, the providers that were struggling were the ones that were serving Black and Brown communities. And so if it wasn't for that, I mean, none of this, would have been possible. The healthcare transformation collaboratives are really looking at innovative ways to address health and social determinants of health with an equity lens. And it's a mix of state funding through like the hospital assessment program, I believe, with a mixture of federal matching funding. And SAFER wouldn't have been in a position to go after this funding if it had not already been on the track of becoming a Medicaid provider. So some of the groundwork had been laid when SAFER, I think a year prior, had become a substance use outpatient treatment provider, Medicaid license, contract to managed care plans. And then during the pandemic, we decided to expand to community mental health, to provide mental health services, because they're siloed where we are. And a lot of the stuff that is now was because SAFER had to build it. We had to build it. The network had to build it. IDOC had to build a system that worked. Mm-hmm. So, okay, it's going to take 3 months to get into a mental health outpatient clinic. We're going to build mental health capacity internally. Okay, the buses aren't running for third shift to get to warehouse. Okay, we're going to partner with this mom and pop agency called Get to Work. And in order for them to help us, we had to help them. We had to sit down with them, get them organized, sophisticated, so that they could be in a position to receive money to then help us. So there's a lot of stuff that goes into it. And I think this is all important lessons, especially as our state is waiting for an 1115 waiver to be approved. Hopefully, and a lot of that's going to have to deal with reentry and employment and housing. And so we believe that a lot of lessons have been learned that will hopefully inform our state's implementation of that waiver. And so I just also want to say that when we first went after this funding, even internally, we were like, we're not healthcare providers. That's not our domain. And I remember telling folks, we're what they're looking for, whether or not they know it. You know what I'm saying? Because people get so caught up on terminology, and each silo has its own terms. But at the end of the day, everything we were doing was focused on equity and focused on access to health and social determinants of health. So thank you.
So we have, let's just take 1 minute. Could you talk about what's next for the for the Supportive Reentry Network Collaborative, and then we'll launch into questions.
The 15 waiver is coming. And we have 2 more years of our HTC. Very happy. Thank you, HFS. That's going to happen. So we're going to be leaning in the next 2 years. We're going to continue to refine, our processes, working with our partners, including IDOC. We're getting off the ground really now with Cook County Jail. We're going to continue to build up our infrastructure because we understand how important it is as authorized agent to the collaborative. If we can't report on what we're doing to show our achievements and show the improved health outcomes and help pertaining to health as well as behavioral health and health-related social needs, then it's for nothing. So, and also building out our billing infrastructure. We're going to, there are going to be a lot of new services that we're going to be able to bill for. So getting that off the ground, as well as incorporating and enhancing, I think, some of our services, like we want to bring on board probably veteran services for the HTC, as well as potentially MAT. For the waiver, there is supportive employment that's coming in, as well as housing that's going to be covered. So looking to see how we can kind of integrate all of that, as we already are doing supportive employment. So we just want to make sure that it's really flowing. And as well as increasing transportation services. We are looking at expanding to other counties. And as well with IDOC, hopefully we can expand to other facilities. We just need to bring more navigators on board.
All right. We have some questions.
Yeah, I think we'll start with one virtual question, which is, what issues or differences do you see for people who are in Medicare and Medicaid, and how do you think policies need to change to address them?
A lot of our population are dual eligibles. I don't know if that's, what they're, in Illinois, that's what they're referred to as, or MMAI. A lot of folks, there's a large issue with folks coming out, and Angie can talk about this better than I can. Our prison population is aging, and people are coming out and are needing different services, and there really is a large need for nursing home type care and other types of services that is not talked about enough. So Angie, do you want to add on to that?
Sure. So we're able to get people into nursing home settings, but to divert just a little bit, it's very hard with criminal histories. And nursing homes are privately owned, right? So they can choose to accept who they want to admit and who they don't. And so that's been an enormous issue and a huge shift for us, is our population in IDOC custody, as I'm sure this is a nationwide trend, is aging. And so people are coming out needing those care, that level of care, right? Or medical respite, or kind of all of the things that come along with that. And it, does become difficult with different criminal backgrounds.
I'll just say this much about the MMAI. It's the Medicare Medicaid Alignment Initiative. I know a lot of states have them. We have it in Illinois. So our FQHC partner and our hospital partners are the ones who really are doing the braiding around Medicare and Medicaid, while our reentry navigators and other providers are kind of addressing some of the health-related social needs. But again, it takes a village. They're all working together and sitting down monthly to be coordinating around these benefits.
Hi, good afternoon. My name is Natalie Ocean, and thank you all for your comments and the work that you all are doing. I work for an organization that helps healthcare organizations find inclusive and reliable transportation for individuals trying to get to and from healthcare services. And I know that you all mentioned that your focus in the program, or one of the main areas of need, was for transportation to work. But curious to know if you've heard any insights and needs around transportation to accessing medical services, in addition to those that are trying to just remain compliant with their parole requirements.
Well, in our state, we recently, our Medicaid agency revamped some transportation. Were you going to talk about that, or?
No.
Oh, okay. And then I'll hand it over to you. But so we have now improved and increased transportation to medical appointments, but we still have, and I'm going to have Sherie is going to speak to this, a lot of challenges around getting people to work and to non-medical appointments.
In addition to that, our state criminal justice information authority, I know every state has one, put out a RFP for transportation, specifically for folks I think involved in the justice system. And so I just want to say that I think a lot of this work it requires the people to advocate for what is not there.
Mm-hmm.
And to also be able to kind of talk the language of two different systems to I think a lot of times people just don't do things because they don't know how or because they don't understand. And so we're really grateful for IDOC being at the table, talking with our state Medicaid agency, and also talking with our criminal justice information authority. Like there's some real change agents at all of these agencies, and I'm so grateful that transportation is being recognized, especially for people that are coming home to areas outside of the Chicagoland area. And so I know it's a big need in Southern and Central Illinois. So I was just going to mention, some of the efforts outside of Medicaid, but I think it works. It takes a village. So partnering, so our state Medicaid agency partnering with all of these different agencies and kind of collaborating on RFPs, and then technical assistance to providers. Like there's just a lot, I think that is possible when that happens, including transportation.
So, and to answer, so for the SRNC, we use Lyft. So we use the funding that we get, through client assistance to be able to get them to those appointments. But yes, we definitely coordinate that as a regular thing that our navigators will do. Especially when we're like setting appointments for whatever referral that we're doing, we do assist them, and going. But I do think to what Sherie was just mentioning, I do think that there just needs to be more dedicated focus on that, and providing some support around that.
I would say we do a really good job at the SRNC of braiding dollars. You can't do a model like this if you're not braiding your money, between braiding subsidies that we got from philanthropy for housing, between braiding, we actually had an MCO foundation give us money to buy a building, right? We were able to braid a lot of these opportunities. Now, don't get me wrong, that MCO didn't think of that by themselves, right? A lot of that was QA money that had not been used during COVID. So they had a little help from legislators and others. But I think we had to be really creative, and we were really not lucky, we were good. And so the governor's office got behind us, as did the Medicaid agency, to really support SAFER, and our network partners to do this work.
Hi, my name is Anna Reisner, and I work at Understep with the Health Center programs. We provide funding to FQHCs and have a funding opportunity out right now.
Yep, we're looking at it. We just had a meeting about it yesterday.
So I think regardless of whether or not all submitters are going to apply for this funding, I'm wondering, for primary care providers who are maybe just not as well versed with this population, what types of things do you think that they could do even, immediately, just to support folks who are coming into the clinic? If a pregnant person presents in front of one of these providers, they know that there are certain questions that they should ask, and there's tailored care that they should be giving them. And it sounds like it's similar for these types of groups who are coming in. So what advice do you have it should be looking at that they might not already be?
I have thoughts, but I want to.
No,
Do you have any immediate?
Sodiqa, I mean, the first thing that came to my mind is that I believe that it's very important for all frontline facing staff to be trained in trauma informed practice, because a lot of times I think the individuals that we serve probably have had negative experiences in healthcare, dismissed, especially if they have Medicaid, not taken seriously, treated like they're on the assembly line. That makes people walk out of offices. And so that's off the top of my head, one of the first things, because I think the reason why we are able to be successful in working with individuals is because they're coming and they feel like they can trust us because we're relatable. And because they know that there are people who have went through the same experiences that they had. And so being sensitive on your assessments as well, in terms of like what questions you're asking and how the process will flow.
I think along those lines, I would also say trying to be intentional about hiring people that are from the same communities. There's a high prevalence of involvement in justice system in Black and brown communities, and so I think if you hire, if you're intentional with trying to hire or trying to partner. I know Safer has a lot of programmings where you can partner people who are formerly incarcerated, like the use of peers. I think that's probably one of the, in addition to trauma-informed training, is one of the most important things you can do, because people are gonna be more trusting and open to someone who's been through what they've been through.
So in other words, hire from the community.
Yeah.
Yay!
And FQHCs are good at doing that. But one of the things we did learn as a network collaborative that we needed to sit down and be very intentional about health literacy and having every partner get some information about it, whether it's our transportation partner, our behavioral health partner. We needed to talk about the importance of primary care and the importance of, so we did a lot of cross training, and we saw just in 1 year of doing that cross training that our primary care visits increased by 13%. So it's this constant talking and learning. We created really a learning collaborative. And that's something I think that has really made us stronger and better throughout the process.
You mentioned assessments, and I think a lot of health centers are intent on having those HRSN screeners, but are there gaps in what you've seen in, Prepare and some of these other basic screeners? Should there be a question about if a person is transitioning like incarceration, or is that, not the right question to ask? Are there more questions that should be on there to help them provide?
That's been asked before. It's been asked, I think when the state was looking at health homes, our state was looking at health homes, it was asked about that because how do you know otherwise? I think it warrants more discussion because there's a stigma, I think, when it comes to asking that. I think when it comes to screeners, a lot of people don't identify as having a mental health issue. A lot of the stuff that they've been through is just normal. It's just things that happen as a part of living the life of the struggle, so to speak. There is a push to put the post-incarceration syndrome to be recognized in the DSM-5, just by virtue of being incarcerated. There's a trauma, and if that is recognized, then people will have more access to benefits by virtue of them coming out. And so I think we need to kind of look at, we need to have like a deeper conversation about mental health, about the role that society plays in the mental health of Black and brown people historically, and some people just don't identify with that. But they're actually eligible for the things that you're trying to provide. You know what I'm saying? So how do we connect the dots without but mold around the person instead of trying to make the person jump into all these hoops.
We're actually using the HRSA grant as an opportunity for us. We were talking about this yesterday in our meeting, to think about questions like that and to think about what kind of training we could be bringing, and how we can do more pre-release, which the grant allows us to do because, as you know, Medicaid won't pay for any pre-release. So our time is up. We really appreciate your attention. Our slides, we have like 40 plus slides that we did not want to be flashing to you, but they will be disseminated. And we really appreciate your attention, and thank you for being patient with how we chose to approach this.
Thanks for being here.